Hello, and thank you for joining us. My name is Dawn Cullum, and I am the Senior Events and Training Coordinator for Certara University. As regulators and sponsors, Certara recognizes the growing importance of model-informed drug development. We are committed to educating the next generation of experts in this field by partnering with eminent scientists at designated academic centers of excellence around the world. This year, our Express webinars are being conducted by our partners and centers of excellence. Today's speaker is Dr. Thomas Henthorn, who is with the University of Colorado School of Medicine. He was the chair of the Department of Anesthesiology until 2016. There, he conducted clinical pharmacologic research with special interest in pharmacokinetics of drug distribution, metabolism, pharmacogenics, drug transporters, and pharmacodynamics. He partnered with the University of Washington, Seattle to design and conduct cellular, animal, human subject, and clinical drug trials, having extensive experience in developing complex PK/PD models, including pulmonary uptake and drug inhalation clinical data sets using SAM2 software. Recently, Dr. Henthorn did a sabbatical in the Netherlands, where he was jointly appointed as a visiting scientist in the Department of Anesthesiologists at Leiden University Medical Center and the Leiden Academic Center for Drug Research of Leiden University. This opportunity allowed him to gain expertise in population PK/PD and exposure to modern pharmacometrics and the inhalation kinetics of ketamine. He now assists with the analysis of clinical study and clinical trial data of mainly perioperative, CNS, and analgesic drugs, along with research involving cannabis and cannabinoids. We ask that if you have any questions, please put them in the question section, and we will answer as many as we can at the end of the webinar. Dr. Henthorn, I'm now going to turn this over to you.
Thanks so much for the introduction, the very kind introduction, Dawn. I chose this topic of lidocaine clearance for a number of reasons. One of them was that lidocaine is a prototypic flow-limited hepatic clearance drug. Also, this is a sparse data set, which makes it interesting. And also, we will be talking about using Phoenix NLME to develop a time-varying covariate and how that looks. This will be a combination of overview and kind of in the weeds screenshots from Phoenix NLME. So I hope you'll bear with me over the next 25 minutes as we examine these issues. So let's talk about lidocaine clearance and why it is considered a prototypic drug for flow-limited metabolism. First, let's look at what that means. So hepatic blood clearance can be thought of as the product of the hepatic extraction ratio and the hepatic blood flow. For those of you who are physiologically minded, you would know that liver blood flow is approximately 1.5 liters per minute. So if all the blood was cleared, then we would expect to have a maximum liver clearance of approximately 1.5 liters per minute. But there's also an extraction ratio applied in this equation, And that depends on the intrinsic ability of the enzymes in the liver to clear the drug. And that equation is the ratio of the intrinsic clearance divided by the sum of the hepatic blood flow and the value for the intrinsic clearance. And this is a nonlinear equation, which of course would reduce at its limits. So at one limit, where the intrinsic clearance greatly exceeds the hepatic blood flow, then EH approaches 1 and the clearance approaches hepatic blood flow. In the opposite situation, where intrinsic clearance is much less than hepatic blood flow, then the extraction ratio gets small, and anything under about 0.1, under about 0.4 would be considered intermediate or low extraction. And of course, it wouldn't reach 0 if there was any metabolism at all, but that's the limit. So let's look at lidocaine again. Lidocaine is metabolized by both CYP3A4 and CYP1A2. It is first converted to monoethyl glycine xylidide, or MEGX, and it is considered both equipotent from a therapeutic and, more importantly, a toxic point of view. And then that MEGX is further converted to glycine xylidide, or GX, and that is only 20% as potent. So the literature value for lidocaine clearance varies between about 0.8 and 1.2 liters per minute, depending on the study. I like to use 1 whenever possible. It's a nice number. And so the extraction ratio is around 0.7, making lidocaine in the category of a flow-limited metabolism drug. So let's talk a little bit about this setting that we will be looking at, and it is living donor liver transplantation. So if someone's on the liver transplantation list, they could have the surgery electively and not wait for a cadaveric donor. And this way they could have the surgery when they're more or less in optimum medical condition for somebody who's got a failing liver. And they happen to know somebody who they can arrange to, and it's usually a family member who's going to donate a significant part of their liver. Both the graft that is put in the recipient and the remaining liver in the donor will eventually regenerate to its original size. The surgery involves right upper quadrant abdominal surgery. And if you know anything about that kind of surgery, it's right under your rib cage. It's very painful in the postoperative period for the donor. And it also carries a significant risk of development of a chronic pain syndrome. So to ameliorate this, most medical centers that perform living donor liver transplant use multiple drugs, such as opioids, dexmedetomidine, lidocaine, NSAIDs, and or other modalities like epidural to treat acute pain postoperatively and hopefully to prevent the development of chronic postoperative pain. At the University of Colorado, lidocaine infusion is used as one of the methods of analgesic therapy. But unlike other abdominal surgeries or other surgeries in which lidocaine is used, the anesthesiology team elects to stop the infusion at the time of hepatectomy due to concerns for lidocaine toxicity. So the liver transplant anesthesia team developed this protocol to examine 2 hypotheses. One, the first hypothesis was that lidocaine elimination clearance is reduced by partial hepatectomy. And if you have a reduced elimination clearance, it raises the concern for toxicity. And so the second hypothesis was that the combination of lidocaine and its two active metabolites, MEGX and GX, don't reach toxic thresholds at any point during the surgery or the first day postoperatively. So this was a biobank protocol, and biobank protocol at the University of Colorado allows for the obtaining of up to 30 mils of blood from any patient that signs an admission consent when they enter the hospital to store anonymously and use in studies by a later analysis. So in this case, the 30 ml were divided into 6 5 ml blood samples that were obtained for later analysis on all the patients admitted to the hospital. The times these were drawn were at baseline, 15 minutes after the start of the lidocaine infusion during surgery, approximately 30 minutes before the removal of the liver graft, 30 minutes after removal of the liver graft, at the end of the time in the OR as the patient was being moved to the recovery room, and then 24 hours later. These samples were measured, sent to the lab and measured for lidocaine, MEGX, and GX by LC-MS. So we were able to study 15 consecutive patients having donor hepatectomies. A decision about the liver resection plan, or how much of the liver was going to be removed, is done on the basis of the anatomy of the donor's liver, and specifically their vasculature, and what can be safely removed, and also what can be hooked up, if you will, to the recipient. So this means that the partial hepatectomy can vary from being as small as 25% of the liver to as much as 75%. And the total liver volume is determined preoperatively by 3D imaging, and then that is examined to figure out how big the graft is going to be, and to develop a surgical plan preoperatively. We also know the size of the donor graft because it is weighed upon removal and before being sent to the other operating room where the recipient is waiting. So let's look at our data. So the first glance here is the lidocaine plasma concentrations as blue circles, and the contribution of MEGX and GX and lidocaine together as the orange diamonds, to see if any of the concentrations were potentially toxic. There was one drawn immediately after a bolus injection that was just above the very conservative number of 5 micrograms per mil, which is the bottom end of the potentially toxic threshold. So the one hypothesis that this was a safe practice was met and examined. So this shows each individual as a gray line, their lidocaine concentrations. The dark line is the lowest smooth curve. And you can see that it stays near what's considered the analgesic efficacy line of 1 microgram per mil. But I want to draw your attention to the red line, and this is based on kind of a consensus from the literature of what a model of lidocaine should look like in normal individuals that are not having surgery and certainly not having part of their liver removed. And you can see that the kinetics are dramatically different in this patient population than what was expected. So let's dive into the pharmacokinetic analysis a little bit. This is the a data sheet for Phoenix NLME. Let's look at just one of the subjects, and it shows the 6 blood levels that were drawn and the times. I wanted to draw your attention to the first 3 time points. At time 0, there's a bolus of lidocaine given that's 40, and as you can see, it varies from patient to patient. It can be as low as 40 or as high as about 80. And then at 50 minutes in, a infusion is started that ran for 100 minutes. And then about supposed to be at 15 minutes, but in this case it was 20 minutes after was the very first blood level. Here we see the covariates that are normally collected, such as age, sex, height, and weight. Just next to that are all these interesting, I consider them interesting, potential covariates that involve the liver volume that was measured by 3D imaging, the estimated graft also by 3D imaging, the weight of the actual graft after it was removed, the fraction of the graft of the total volume, and then what we will end up using, which is how much of the graft was left in the donor, which is simply 1 minus this value. So let's look at the pharmacokinetic analysis in Phoenix NLME. You see we have a 2-compartment model. We tested a 1, a 2, and a 3 compartment for which one was most parsimonious. A 2 was the most parsimonious model. And then down here we have the covariate selection page and the structure of the parameters. And here we have the total body weight, and we included it on the central volume, the peripheral volume, and clearance. And this just shows that this is the normal way when you click yes on the covariate, it shows up as the covariate, and then the covariate effect, which will show up as a parameter in your model. And you can either have them on or off. But in the case of the fraction left, we use the 1 plus method of putting it in, which makes it a proportionality. And here's the equation. I'm going to bring it up a little more so that you can see it more clearly. And this shows that clearance or theta in the ith individual is equal to the typical value of clearance or theta times this relationship that is applied when you use the plus 1. So it's 1 plus the liver remaining minus 1 times the effect of the covariate. And if it's truly proportional, you would expect this value to be close to 1. And then the inter-individual variability is applied for each individual. So if you imagine that half of the liver is removed, that means half is remaining. So you put in 0.5 and you expect it to be absolutely proportional and that the effect of the covariate value would be 1, then it would be the clearance would be the typical value times 0.5, and then the inter-individual variability applied to that. So it's really pretty simple, and that's kind of the way that this modality in Phoenix works. So let's return to the data, and let's look at how it's entered. So we go back to the subject and the different times throughout the operation and post-operative period. And at the beginning, the value is 1 because they have their entire liver, so the liver is intact. At about 150 minutes into the procedure, the graft is isolated, meaning that the surgeons have dissected or bisected the liver and have put not clamps yet, but they put strings, not strings, but you know what I mean. They've looped and isolated and controlled the blood vessels. And at this point, we consider the liver to be isolated and not functioning in this portion. So that we, at this time point, this makes this a time varying covariate, and so it begins the time when the liver is reduced in size. And these are the stepwise covariate search for both weight and the fraction left. And you can see that after the step 4 of the covariate search, the fraction left is the applied to the elimination clearance is the only one that comes through. These are the model performance parameters. This is the conditional weighted residuals as against concentration. And you can see there's quite a bit of scatter, but most of it's between 2 and -2. And there's a good central tendency. The one I was most concerned with when I was doing the data analysis was the weighted residuals versus time. And that's because, if you remember, we have a time-dependent covariate, and we would like to, and there's a vast difference in the physiology of the patient at the beginning here and at the end, and you can see that we've nicely captured the time dependency of the patient's conditions. And this is just another graph that shows the predicted versus observed. And there's scatter, as you would expect. This is not somebody in a CRO laying quietly. This is somebody who's bleeding, getting blood transfusions, and fluid resuscitation and other things. You would expect there to be movement around the mean or the identity, so it's not surprising. Again, looking back at Phoenix and NLME, this is step 4 that was carried through, and I just want to draw your attention to the coefficient of variation for the parameters, and they were all acceptable except for maybe the volume of the second compartment, but we didn't have, remember this was sparse data, and we don't have a lot of information about drug distribution here, so I considered these pretty acceptable given the conditions. And then another thing that we should look at when we have a covariate is what does the scatter or the variance of the parameters with and without the covariate. So here's the omega table, and you can see volume and clearance variance here. And then with the covariates, both of them are significantly reduced, meaning that the covariate does explain a significant portion of the variability among the patients. Returning to the theta table, I wanted to draw attention to the fact that the clearance is only 0.54. And remember that from the literature, most people agree that the clearance is between 0.8 and 1.2. So this is shows that elimination clearance before removal of the part of the liver, that clearance is reduced. And there have been studies done in the past that have looked at liver blood flow during open abdominal surgery and anesthesia, and it is reduced by approximately half. So this value for clearance is not all that surprising, being nearly half of what you would expect. This is the covariate, the effect of the covariate. So and it's larger than 1. Remember, we were expecting, or I was expecting it to be close to 1, and it was larger. So our conclusions were that lidocaine elimination clearance is reduced by partial hepatectomy. It's nearly proportional to the fraction of the liver remaining. However, it was 30% higher than unity, suggests that something's going on. And my interpretation is that there's enhanced blood flow to the remaining liver, thus boosting its clearance slightly. And by developing this model, we can now develop a rational basis for continuing lidocaine into the postoperative period following donor hepatectomy. Remember, it was turned off as soon as the graft was isolated. So these patients were getting approximately 70 milligrams an hour. And how would we adjust that? In the case of removing the right lobe, which is the most common graft to remove, and that results in removing slightly over half of the liver. So you would have around 44.5 remaining after graft resection on average. So we go back to the theta table and we can develop the following equation. So if you think about designing an infusion at steady state, times the elimination, steady state concentration times the elimination clearance should give you your infusion rate. So if the target is approximately 1 microgram per mil, you multiply that times the base rate at the beginning of surgery, apply the fraction of the liver remaining, and the effect of this covariate, and you multiply that out, you end up with a dramatically reduced infusion rate of about 19 milligrams an hour. Obviously, further studies are needed to better define the lidocaine pharmacokinetics in these and other hepatectomy patients. What would be ideal would be to develop a protocol in which we can study these patients in the days or weeks before their surgery and follow them into surgery. If we were to institute a reduced infusion rate and continue it into the postoperative period after hepatectomy, this would need to be verified and validated. And another thing to consider is that lidocaine is a prototypic flow-limited drug, so other flow-limited drugs would also have similar effects in this population of patients. And this would include the opioids that are used, ketamine, dexmedetomidine, and other drugs that are used in the operative care and the postoperative care of hepatectomy patients. Hepatectomies are also done for cancer surgery, for instance. The time-dependent covariate, the fraction of the original liver size, may be useful to estimate the time course of clearance changes in both the recipient and in the people having, or the patients having donor or other kinds of hepatectomy. And it's important to keep in mind that this time-dependent covariate may vary according to the enzymatic pathway and the substrate, because it's an interaction there. So intrinsic clearance would be of importance, as would the extraction ratio. And I want to thank you for paying attention to this short presentation and to draw your attention to the fact that there's more of these webinars coming, and I'm open to taking questions. Thank you.
Okay, we do have one question, and that is, what do you make of the parameter estimating the covariant effect of the fraction of liver remaining being greater than 1.1? I'm sorry, 1.0. And would this not result in the production of lidocaine if less than 20% of the liver was remaining after the partial hepatectomy?
Yes, that is an interesting conundrum, and it speaks to how we always should caution not extrapolating our results beyond what we studied. So here the range was from around 20%, I think it was in the mid-20s, to 80% of the liver being resected. And yes, if you go beyond that to not quite to the extreme, it would look like the body would produce lidocaine. It's kind of an interesting idea. We of course know that would not happen, but it speaks to the idea that it's dangerous to extrapolate pharmacokinetics beyond what was actually studied.
We are running very short on time, and someone has asked if this is going to be shared, and it is. We are recording the webinar, and you will have access to it to view probably tomorrow. Dr. Henthorn, I'd like to thank you for your presentation and the audience for joining us today. Our next COE Express webinar will be Tuesday, October the 18th, when Dr. Ronat Gehring will discuss the physiological basis of comparative pharmacometrics. I just cannot speak science today, guys. Sorry. We hope that you will join us and hope that you have a great day. Thank you.